Thank you. Welcome to the webinar. This is Namita Reddy. I am with the New Jersey Department of Health Communicable Disease Service. Thank you all for attending. Before we start, a couple of notes about programmatic updates and information about continuing education credits. Today's program is approved for 2 public health credits and 2 nursing contact hours. I will go over the specific details on how credits will work toward the end, but for those people watching as a part of a group, please send in a group sign-in sheet for each of your locations. We will take questions at the end of each session, and we also have a general question and answer session at the end. To ask a question, you can type a question into the questions or chat box at any time. And if we don't have time to address any of these questions, I will make sure to send answers out after the webinar. Also, we will be recording and archiving today's webinar, but please note that no credits will be offered for watching the recording. Presentation slides are posted on NJLMN under Practice Exchange. There are a couple of ways in which you could actually reach the slides. As a reminder, the webinar recording is located here. You could reach that through our public health website, through the Department of Health page. When the orange screen opens up, click on Communicable Disease, and on the next page, you can see the button in the lower right that says Communicable Disease Training Resources. And this is where it will be. Also, please note that it may take about a week or so for our slides to get posted, and the direct link is right here. A few programmatic updates. We have updated case definitions and new case creation timeframes for 3 foodborne diseases: non-typhoid salmonellosis, shigellosis, and vibriosis other than cholera. So a case that tests positive by non-culture diagnostic methods, for example, through PCR, would now get classified as a probable case. We are no longer using possible case definition, and once you classify it as a probable case, you would have the option of a drop-down where you could particularly choose whether it's culture-independent diagnostic testing or whether it was epi-linked, and that way we could make sure that all our probable cases are getting classified appropriately. The other thing that has changed would be the lab time. A lab result will get added to the existing case, and a new case will not be created in CDRSS if it meets the following criteria. So for salmonellosis, if you have a lab report that comes in within 365 days of a previously reported infection in the same individual, there will be no new report created for that individual. For Shigella, if a previously reported infection lab report is received within 90 days of a previously reported infection in the same individual, a new lab report will not be created. For Vibrio, again, the timeline is within 30 days. So if you have a lab report that occurs within 30 days of a previously reported infection in the same individual, there will be no CDRSS report created. But the only exception for this rule is when 2 or more different serotypes are identified from the same individual, then each would have to be manually reported into CDRSS as a separate case, irrespective of the above time frames. You will be getting a link message with additional details, and that should clarify the process further. Here is the agenda for today. It is a full agenda, and we hope to be able to address all of your questions at the end of each presentation as well. Again, nursing disclosures. No commercial support has influenced the planning of the educational objectives and content of this event. No influential relationships have been disclosed by planners or presenters, which will influence the planning of this activity. If any arises, an announcement will be made at the beginning of the session. There is also no endorsement of any product by the New Jersey SNA or ANCC associated with this session. This is reiterating the same thing. And our first presenter is Susan. Susan Hannigan is a surveillance specialist at the Department of Health's Vaccine Preventable Disease Program, and she will be talking about acute flaccid myelitis.
Good morning, everyone. My name is Susan Hannigan, and I am going to be giving you an introduction today to acute flaccid myelitis, which is a condition that we are just starting to do surveillance for here in New Jersey. So just a quick overview of what I'm going to go through today. I'm going to give you a background to acute flaccid myelitis, review some of the surveillance that CDC is doing, as well as our surveillance efforts here in New Jersey, and go through some of the steps of case investigation. So we're going to get started today with a poll question. Okay. So our question is, the New Jersey Health Department sent out a links message in October regarding AFM. Do you recall seeing this message? A, yes, I read this message. B, yes, I saw this message but did not read it. C, I do get links messages but do not recall this message. And D, I don't get links messages. Okay, great. So this is just a question with not a correct answer, obviously, but we just want to gauge how well our messaging is reaching. So I'm glad to see that a lot of people did read this message, or at least if they did not read this message, that they do get links messages. If you don't get links messages and you're interested in getting links messages, you can reach out to your regional EPI who can get you in touch with the links coordinator to get links messages. But for those of you that did read the links message, hopefully today's presentation will just give you a little bit of some updates and some more information after that brief introduction to AFM. So what is AFM? AFM stands for acute flaccid myelitis, and it's a condition that affects the spinal cord. The main symptom that it's characterized by is a sudden onset of limb weakness and a loss of muscle tone and reflexes in the limb that is weak. This can also be accompanied by a couple possible symptoms, including facial droop, difficulty moving the eyes, drooping eyelids, difficulty swallowing or speaking, pain in the arms or legs, being unable to pass urine, and one of the severe symptoms can occur if the muscles that are involved in breathing become weak, which can result in respiratory failure and the need of ventilator support. So why is CDC interested in AFM? This is a serious illness. We don't know the cause of it and how to prevent it. And it additionally appears to be increasing. The thing about AFM is the surveillance is really new. So by hopefully expanding the surveillance, we can determine whether it's actually increasing, what the baseline is, and answer some of these other questions about the illness itself. So where did AFM come from? AFM first entered CDC's radar on September 12th of 2014. They were notified by the Colorado Department of Public Health of 9 children with a neurologic illness with unknown etiology. So this illness was presenting acute focal limb weakness and lesions in the gray matter of the spinal cord on MRI. As a result of this, CDC issued a national health advisory calling for cases on September 26th of 2014 to try to get a sense of if places other than Colorado were seeing this illness. They set their case definition as the clinical presentation that I just mentioned, and with children that were 21 years or younger. So as a result of that health advisory, they began receiving more reports and ended up with a total of 120 confirmed cases from 34 states for 2014. The onsets of illness were between August 1st and December 31st of 2014, and the median age was 7.1 years. What's really interesting about this is the increase in cases, or the supposed increase in cases, coincided with a national outbreak of severe respiratory illness that was caused by Enterovirus D68, or EVD68. So it was thought that it was possible that this EVD68 was causing AFM in these children. However, despite extensive testing of laboratory specimens from these cases, CDC was not able to consistently identify EVD68 in specimens from these patients. So they weren't able to make the conclusion that this was the cause of these illnesses. So since then, CDC has been continuing to try to collect reports of cases, and this graph here just shows by month the number of confirmed AFM cases reported to CDC. It goes all the way until November of 2016, so we're still waiting on their numbers for December of 2016. And you can see that it starts as a result of that initial report from Colorado in August of 2014. What's interesting, if you can see it in this graph, is that there does appear to be an increase again in 2016. What we don't really know is if this is a true increase or just because this is such a short period of time that we are looking at. Again, this is just about 2 years of data by month. If the data hasn't quite really settled yet, and we're still in the process of trying to establish what a baseline of AFM is. But if it is an increase again in 2016, it is occurring in the same month as the initial increase in 2014, which was late summer, early fall. So this table just reiterates pretty much the same information, looking at the number of confirmed cases, but grouped by year, and then the number of states that are reporting the cases. And again, it's important to note that surveillance is new. You can see 2014 isn't a complete year. It was only starting in August. And in 2016, we're still waiting for the numbers from December. The other thing that's important to note is in 2015, in August, CDC decided to change the case definition. And I'll go a little bit into the case definition later, but they took away the age restriction of having cases be only in people that were 21 years or younger. So after about 2 years of surveillance, what do we know about AFM? Despite changing the case definition and looking at patients of all ages, most patients are still children, and the symptoms of AFM are similar to those caused by some viruses. So it's also been referred to as a polio-like illness because the clinical presentation is similar to what would be caused by poliovirus. But the symptoms are also similar to illnesses that can be caused by West Nile virus, adenoviruses, and non-polio enteroviruses. So enteroviruses like EVD68 can cause neurologic illness. This is something that is known, but this is rare. And in addition, neurologic illnesses can result from a variety of causes. So in addition to viruses, environmental toxins or genetic disorders could cause neurologic illness. So with that being said, there's still a lot that we don't know. As I've mentioned, we don't know what's causing AFM. CDC hasn't been able to consistently identify a pathogen in specimens. We don't know who is at risk and why they might be more at risk. And as a result of not knowing what the cause is, we don't know how to prevent AFM. Additionally, we don't know what the best treatment is or how common AFM is. So as I mentioned, we don't really have a sense of what the numbers look like prior to 2014. We're not sure if AFM has been in existence, and it's just not something that was noticed, and CDC wasn't looking at it. But it's very possible that it wasn't new in 2014. We just don't really know what the prevalence looks like. So by collecting surveillance moving forward, we can determine how common AFM is. So what is CDC doing? Since 2014, they've been continuing to do a lot of work. They're encouraging states to get on board with reporting cases, but then a lot of the work is really on them. They're the ones that are verifying reports of cases and reporting the national case counts on a monthly basis on their website. They've sent out clinical reminders and are really encouraging reporting by clinicians and by states. They're testing specimens that are sent to them for suspect cases. And additionally, they're starting to collaborate with some medical institutions to review past MRIs and look for additional cases of AFM. So as I've mentioned, we don't know what the prevalence of AFM might have been like prior to 2014. So by looking at past MRI reports, they could potentially see if this is something that has been existing and just we haven't been looking at it. So AFM in New Jersey, I came on board in August of 2016, and New Jersey is getting on board with the national surveillance for AFM. So in 2016, we had 6 confirmed cases. The onset dates were all in August and September. And what's interesting is while many of these patients were transferred to or from New Jersey hospitals, 5 of them were actually primarily hospitalized and reported while hospitalized out of state. So 3 of the patients were hospitalized at Children's Hospital of Philadelphia, and 2 were hospitalized at Morgan Stanley Children's Hospital of New York in New York City, which is part of the New York Presbyterian Columbia University Medical Center. The median age of these cases was 4. 5 of the cases were children between the ages of 2 and 8, but we did have a 33-year-old case as well. And in early 2016, in the spring, a case was reported to us that was determined to be a probable case. So now I'm going to go a little bit into the steps of a case investigation. The ideal person to be reporting the case is a physician, and we want the physician to report the cases to us here at the New Jersey Health Department. And the physician completes a patient summary form, which just provides clinical information on the patient. And then NJDOH coordinates the shipment of specimens to CDC's lab for testing, as well as sending the patient summary form and MRI reports to CDC. And a CDC neurologist reviews this patient summary form and the MRI reports to determine whether the case meets case status. So for specimens, I've mentioned a little bit about CDC testing specimens. The specimens that CDC is interested in are CSF, serum, whole blood, and stool specimens. And they ideally would like to receive each of these for any suspect cases. Just an example of how things have already changed. Initially, when we sent out our links message in October, CDC was interested in receiving all of these as well as respiratory specimens, but they've since decided as of December that they're no longer interested in respiratory specimens, and they really want to focus on the specimens listed here. CDC's website has very clear instructions for the collection, storage, and shipment of specimens, but it is important to note that the testing that CDC is doing on specimens is not necessarily for clinical purposes. This isn't to help the physician determine how to treat the patient or maybe diagnose them, but it's really for the purposes of CDC trying to figure out what might be causing these cases of AFM. So I've mentioned case definitions. To just go into the specifics. A confirmed case of AFM is a patient that presents with acute onset of focal limb weakness and an MRI that shows a spinal cord lesion restricted to the gray matter of the spinal cord. So as you can see from this, in order for a patient to be a confirmed case of AFM, they must have had an MRI done. So it is really important for these cases to have MRIs in order to confirm them as a case of AFM. Without an MRI, a patient could still be classified as a probable case, or without these specific MRI findings. A probable case just needs to have the onset of limb weakness and pleocytosis of CSF. So now we're going to go into our second poll question. So who is responsible for determining if a suspect case of AFM meets case definition? Is it A, NJDOH, B, the physician who reported the case, C, CDC, or D, the local health department? Okay, great. So the correct answer was C, CDC, which I'm glad that most of you picked. Again, while we are on board and we want the physician to be on board with reporting these cases, at this point it really is CDC that's making the determination if a case is a confirmed case of AFM. And we have another poll question. So which forms of communication has the New Jersey Health Department used to send information about AFM? A, links, B, epigram, C, the Regional Epi Program Quarterly Highlight Report, D, none of the above, or E, all of the above? Great, so the correct answer is E, all of the above. And I'll go through that now. We've been trying to be, since we're just newly getting on board with this AFM surveillance, be good about communicating and getting the message out that we're interested in this. So the New Jersey Health Department website has had a section for AFM actually since September of 2015. And again, we sent the links message out in October of 2016, which was our first call really asking for providers to report suspect cases. Because we really want this links message to reach our target audience, we forward the links messages to our contact list of infection preventionists and to a variety of healthcare professional organizations, which I've shown here, as well as school nurses and daycares. Which we thought were maybe some audiences that might be interested in knowing that we were looking for cases of AFM. Additionally, like I mentioned, we did have a brief description of AFM in the Regional Epi Program Quarterly Highlight Report and the statewide highlights. This was Q3 of 2016. We had a short article in the New Jersey Department of Health Matters newsletter. And this should be coming out in a couple of weeks, but the Communicable Disease Service Communicable newsletter, we have an article about AFM as well. And these are just different things that are distributed to public health partners, so we wanted to get the word out about AFM. We also had something in the epigram. So if you guys did see this epigram, you should know the answer to this next poll question. So what is the role of the local health department in AFM case investigations? Is it A, to interview cases, B, initiate prophylaxis of contacts, C, report cases to CDC, or D, refer any reports to the New Jersey Health Department if received, but otherwise nothing? And great, you guys got this one correct. So at this point in time, there is no public health action that's required by local health departments. Again, the surveillance for AFM is really new, and this is likely that it will change moving forward. But at this point in time, all that we ask is that if a provider happens to report a suspect case of AFM to the local health department because they're used to reporting other cases, that you refer those reports to us here at the New Jersey Health Department. So we do want to be transparent and keep local health departments informed of cases while there is no work on your end at this time. Obviously, if we're looking into a suspect case in your jurisdiction, we want you to be aware of it. So far, with the confirmed cases that we have been communicating with local health departments via email. But as of December, we do have a module for AFM in CDRSS. So you can view cases in there. So we'll continue to send you a notification email, but from then on, any case information will just be entered into CDRSS for those cases. And we're keeping the cases in a DHSS status in CDRSS so that they're not showing up in your pending screen. But if you're interested in seeing if a case gets created in your jurisdiction, you can set up notifications in CDRSS for AFM now that there is an AFM module. So some really helpful resources. A lot of the information from this presentation has come from CDC. Their website has a lot of detailed information about specimens, frequently asked questions both for the public and also for physicians. As I mentioned, they do put out the national case counts on a monthly basis. And they do have a guidance document for physicians as far as some notes for clinical management of patients with AFM. Additionally, pretty much all of this information is linked through the NJDOH website. And we are working on, we have a NJDOH frequently asked questions document for AFM that's in the approval process, so that should get posted to the website very soon. So just to wrap up some key points, CDC is interested in reports of suspect cases of AFM. This is a disease that there is a lot unknown, and the only way that you can answer these questions is by doing surveillance. It's important to note that AFM is not a nationally notifiable condition, so at this point reporting is mandatory, but it's not mandatory, sorry. But the New Jersey Health Department is joining this national surveillance. Again, the case investigations for AFM and the surveillance is new and changing, and there will be a lot of updates along the way, which we'll continue to keep you guys informed about. And there will probably be some more resources that are coming soon. And lastly, AFM is a serious condition. It does result in sometimes long-term paralysis, and obviously this is concerning, especially in children. But as of right now, it is rare. It's less than 1 in a million. It's the likelihood of having AFM. So with that, I'll open up for any questions.
Thank you, Susan. The first question here, do you want to read the question? And then
sure. Did the CDC determine whether the confirmed cases of AFM were ever vaccinated against polio or immunized properly in accordance with the current CDC guidelines? That's a great question. So part of the patient summary form, which collects clinical information, does ask if the patient was immunized against polio. And I believe that most cases, I mean, in the U.S., our rates for polio vaccination are very high. So they have not noticed anything in any of the cases that would indicate that it was actually caused by polio. But that's a great question. And with this surveillance, they do want to continue to make sure that it's not polio that is causing this.
Please type in your questions in the question box, and we should be able to address them.
Yes. So the next question we got is, do you think because of the seasonal occurrence, it may be related to mosquitoes? So that's also an interesting question. CDC does have that AFM, an illness like AFM or AFM itself could be caused by West Nile virus, but they have not detected that any of the specific cases have been caused by this. So it's definitely something that they're still considering. They do have as part of their guidance to possibly prevent AFM to protect against mosquito bites, but we don't really know if this is actually the cause.
All right, thank you, Susan. If you have any additional questions, please feel free to send them in. If we do not have time toward the end of the presentation, we will be able to address it via email at some time after the webinar. Our next person on the agenda is Elizabeth Zaremski. Elizabeth is the surveillance coordinator for the Vaccine Preventable Disease Program at the Department of Health, and she will be talking about Haemophilus influenzae. Elizabeth.
Hi, good morning all. I just wanted to give you guys a very brief presentation on Haemophilus influenzae and give you some answers to some common questions that we've been receiving, along with just a minor laboratory update. And as usual, I probably will speak a little too quickly, so if you have any questions, you can always contact me afterwards. H. flu, as you know, is an immediately reportable condition. It should not be confused with influenza. Haemophilus influenzae is a bacteria and flu is a virus. They are very different. We are concerned specifically with invasive disease similar to Neisseria meningitidis, and this means that we are concerned with specimens that are collected only from normally sterile sites, for example, blood or CSF. And H. influenzae has been identified in those specimens by culture or PCR. A list of these normally sterile sites is available on our website at the link on your slide. We do get lots of questions about the different types of serotypes. Haemophilus influenzae has encapsulated or typable strains and an unencapsulated non-typable strain. There are 6 different encapsulated types, and these are designated as types A through F. That includes the Haemophilus influenzae serotype B. And then the unencapsulated one is non-typable, and that's actually considered its own type. So when you see non-typable in the system once we get an update from PHEL, that's actually a type. That doesn't mean that it's not Haemophilus influenzae. There are currently no vaccines to prevent disease caused by non-B encapsulated or non-typable strains. While H. flu serotype B, or Hib, is the type that we're most concerned with and that requires public health response, all Haemophilus influenzae is reportable regardless of the serotype result and would be classified as a confirmed Haemophilus influenzae if it's identified. We are concerned with B, but serotype is not known when we need to start public health response usually. Often you just get the culture positive result and need to proceed with public health investigation prior to knowing what the actual serotype is. If H. flu is isolated from a specimen from a normally sterile site, the testing lab is required to submit it to PHEL for serotype testing within 3 days of identification. Hospitals do not currently have their own serotyping methods. Unfortunately, our regs currently do have an error stating that only CSF and blood must be submitted to us, but it actually should be from all normally sterile sites, just like meningococcal disease. We're working on getting the language revised. Most hospitals are not aware of the incorrect wording, and those that are have actually been very cooperative in submitting the isolates that we need anyway. So thankfully, it has not caused a big issue. Again, here are links to our list of normally sterile sites that are available on our website. A couple of things I'd like you guys to keep an eye out for. First and foremost, there are occasionally some errors in reporting lab results by humans and also by electronic lab reporting, also known as ELR. So one of the first things you should do is, when you receive an H. flu case, is to actually check the specimen source and make sure that it is actually from a normally sterile site. You should open the lab test itself and look at the full entry. On this slide, you can see that the specimen shows up as whole blood on the lab eval tab, and that's over to the left towards the top, right next to microorganism identified. You can see specimen is whole blood. However, when you open the actual test menu and look down at the lab test comments, if you look to the bottom right part of your screen highlighted in yellow, You can see that it actually is sputum, which is not sterile and does not need to be reported or investigated. I do try to catch these before you start working on them, but it's not always possible, and we don't want you doing unnecessary work. So this is important for you to be aware of this as well. Also, if you see that the case creator is NJDOH electronic, you should definitely look more closely at the lab to see if it needs to be investigated. In addition to differing specimen sources, we have also seen negative lab reports reported by NY, which might not need to be investigated depending on the different diseases. So if you're not sure, you should definitely give us a call and we can help you. Because it's New York, we have little control over what is being submitted by ELR. Just a quick note. You can tell if something has been entered into CDRSS by ELR because there will be a little note in the bottom left-hand corner of the window, the test menu, the test result window. You can see it here circled in red. The regs are available on our website if you ever need to reference them when you're talking to a hospital about submitting isolates to us for serotyping. You can go to our main CDS page and from the left-hand nav bar, select the disease reporting requirements. It's pointed out here on the left with the red arrow. There are a lot of other goodies on this page, including the magnet, which might come in handy if you have a provider who doesn't report appropriately. You'll see another red arrow pointing to the link where you will be able to access our regs. If you have any trouble, we'd be happy to walk you through reviewing them. I've used this reference many times in working with hospital labs regarding the submission of isolates when they were not aware of the requirement. Once you've confirmed that the hospital is submitting the isolate, you should be documenting this information in the lab test section. There are designated data fields. This information helps us ensure that the isolate has arrived to PHEL and ensures more timely results, which could impact public health response. This is an example of a culture-positive result, noted as microorganism identified in the test name. You can see by the red arrows that it's actually coming to PHEL or did come to PHEL on April 2nd, 2014 via courier. If the specimen is coming via FedEx, a tracking number would be great to document, but it's not necessary unless it doesn't arrive, which is very rare. This is important for any specimens coming to us, and we also use it when we're shipping to CDC or Wadsworth or one of our other reference laboratories. I would also like to just quickly review the difference between culture and PCR. With culture, we're actually growing out the organism. It is isolated. Currently, most H. flu cases are reported to us because of a culture-positive result. This is easy because then there will be an isolate that can be sent to PHEL for serotyping. However, we're starting to see more and more cases reported by PCR testing because it's a rapid test with high sensitivity and specificity. Instead of growing out the organism, it's actually amplifying a small segment of the DNA to identify Haemophilus influenzae. A major advantage of the PCR is that it allows for detection of Haemophilus influenzae and actually also Neisseria meningitidis among some other organisms from specimens in which the organism cannot be detected by culture, such as when a patient has been treated with antibiotics before a specimen was obtained for culture. Even when the organisms are non-viable following antibiotics, PCR can still detect Haemophilus influenzae DNA if a sufficient amount is present in those specimens. But there are still some challenges with PCR that we're currently trying to work through. While you get a fast result, the PCR assays that hospitals are currently using do not provide a serotype, and more hospitals are running PCR. In addition, while PHEL can perform serotyping on culture isolates, they do not currently have the capability to run the type of PCR that provides serotype results. So if there is a PCR positive result, and there's no culture growth, and therefore no isolate, we are requesting that any specimen remaining from the PCR positive result be submitted to our PHEL for forwarding on to CDC or another reference lab for additional PCR testing in order to detect the serotype. Hospitals technically are not required by regs currently to submit these types of specimens, but again, when it has come up, the hospital labs have been very cooperative, especially when they understand that the surveillance of the different serotypes is very important. We recently have been given the option to add the methodology to the lab test name to help you more easily recognize the type of test you're seeing a result for, which may affect response or classification. This is an example of how you would see a PCR result come in for H. flu, and that should trigger you to inquire whether a culture is pending. If there is no culture pending or it is negative, the next step would be to request that the hospital submit to PHEL the remaining CSF that gave them this positive result. Finally, I just want to quickly review some of the main key points of HFlu investigations. While it is an immediately reportable condition, it really doesn't take as much time or effort as a meningococcal disease case or a measles case, for example. We already discussed the isolate submission, so I'm going to move on to some other pieces. Hospital admission and discharge dates are important, as CDC does look at this data. As far as treatment, we don't need the full list of meds that a patient is on, just any antibiotics that pertain to treating Haemophilus influenzae, for example, Rocephin. Please do your best to obtain and document Haemophilus influenzae serotype B vaccine dates, the Hib vaccine dates. Please note, it is not necessary to obtain or document any influenza vaccine dates, as they are different from the Haemophilus influenzae serotype B vaccines, and flu vaccine info is not pertinent to HFlu investigations. More and more people are in NJDOH, so this is also a great resource. If you are not yet using NJDOH, you can find out more about registering and training from the link on your slide. If the vaccine dates are not in NJDOH, you should inquire with the patient, parent, or primary care provider. Mortality. For HFlu cases, this is normally the mortality upon discharge, and you can obtain this when you request the discharge date from the hospital. Just be sure to specifically inquire whether the patient was discharged alive. Then, obviously, we need signs and symptoms, and the point of the case investigation is to identify any at-risk close contacts and refer them for prophylaxis. You can see here that the investigator of this case did a very thorough job of documenting the requested info. At the top, next to the first red arrow, you will see the hospital admission and discharge dates for both facilities. Moving down to the next red arrow, you see the antibiotics name and dates. Then, within the immunization section, 4 Hib dates are documented along with the patient's NJDOH registry ID number, and under mortality, the patient did not die. As far as close contacts, there's a great reference chart within the 2015 AAP Red Book 30th edition. I know many of you may not have the most recent version of this text, so I did scan the chart and I have it posted on the HFlu Technical Info tab under the Local Health Department section. For identified at-risk close contacts, obtain and document Hib vaccine dates and refer for prophylaxis if appropriate. Ultimately, it is the contact provider's clinical decision whether or not to order prophylaxis for the contact. If someone is referred for prophy, please document this, and if possible, whether they actually receive the antibiotics. Close contacts can be added under the contact tracing tab. Lastly, we have updated our HFlu's site's resources, but I have not yet finished the chapter, and that is forthcoming. Keep in mind, other than the increased use of PCR, not much has changed for HFlu investigations, and as always, you can call me or your regional epidemiologist with questions. And with that, we'll take any questions.
If you have any questions, please type it in the question box. You could also type in the question and send it to us, and if we do not have time, we will be able to address it via email after the webinar. Next on the presentation on our agenda would be Lisa. Lisa is not a stranger to speaking to the public here. Lisa is the program coordinator for infectious disease epidemiology, and she's also the influenza surveillance coordinator, and she will be providing an update on influenza.
Actually, before I start in on some influenza, thank you, Namita, for your introduction, and good morning, everybody. I just wanted to, we've been having some additional questions about hepatitis C, and so I just want to take a few moments to try to just address some of the questions that I hope may be out there that can help dispel some questions and concerns. So I think, as many of you are aware, Ellen Radowski retired from our service after many years of dedicated service in public health. And I'm sure, as many of you know, she leaves behind a very large gap, and it's very difficult for us to try to fill, but we're doing the best that we possibly can. We do have a staff person, Bernice Carr, who some of you may have spoke to. She was briefly trained by Ellen, and she is currently trying to assist us with Hep C surveillance. So we ask that you try to be as patient as possible with us as we go through this transition. So just a reminder that case closeouts by local health departments are due for March 31st, 2017. And you should be aware that New Jersey is not using the new CSTE case definition, and so you should continue to follow previous guidance that was provided for 2016 case closeouts. For those of you who need some assistance or have some questions about that, Ellen did do a presentation on the Winter 2016 forum that gives actually really good guidance on information that should be collected and how you need to close out cases. And so I would refer you to the web link that's on the screen for Ellen's presentation. She's actually the first presentation on that forum webinar. So one of the common questions that has been coming in that staff have asked me to just update is that if a case is closed in CDRSS, do I need to enter a new lab? And the answer is you do not need to add any additional labs to a confirmed DHSS-approved case of chronic hepatitis C. Only newly diagnosed cases or lab results that would change the case status of an existing case would need to be reported. So moving forward, the plan here for us is that we would really like to begin working to try to implement the new CSTE case definition. And so there's a group of staff here that are working on trying to develop a case investigation guide for local health departments to assist with hepatitis C closures. We're also going to try to explore some of the technology that's available to us in ELR or electronic lab transmissions within CDRSS. So what we're asking is if there are a few local health departments, 2 or 3, who would like to be involved in some of those discussions and provide us some feedback on kind of what we're developing or any suggestions, we would love to hear that. And we'd love to partner with you and be involved in that process as we move forward. You can shoot me an email, and my email is at the end of that slide. So that's just a little overview on Hep C and some of the activities that are going on. And so I'll move into an influenza and respiratory disease update. So I'm going to briefly go through these. Influenza surveillance activities, many of you are already aware of that. We do influenza-like illness at emergency departments, long-term care facilities, and from providers through our ILI-NET program, which is a CDC-run program. We collect information on school absenteeism. We collect influenza cases confirmed by testing, both conducted at the state public health labs, commercial labs, and acute care facilities. And then there are some specific groups, such as those severe and fatal pediatric influenza cases that come into us. So as far as surveillance systems, we use a myriad of different systems in which we collect information, including CDRSS. Many of you are aware of the influenza-like illness module, and this is pretty much designed for schools, long-term care facilities, and emergency departments, but also laboratories go in there and enter rapid influenza testing data along with RSV. And so for the rapid flu and RSV, it's actually the number of positive tests and the total number that are tested within those systems. CDRSS is also a mechanism by which we receive positive influenza test results. Influenza is a laboratory reportable condition, and we did issue a memo at the beginning of the flu season which describes that. And essentially, if facilities are connected via ELR to CDRSS, we ask that they submit all influenza positives regardless of the testing type. So that would be both rapid and PCR. CDRSS is also used to collect information on our pediatric influenza cases. There's an additional survey that pops up under the epidemiology tab, which we use to collect additional information from those cases. We use Epicenter, which is the state's syndromic surveillance system for emergency department visits and admission data. We look at that regularly, and anomalies for influenza-like illness and other respiratory illnesses are looked at on a regular basis by our regional epidemiology program. There are several CDC systems, including ILI-NET, which monitors outpatient visits, and vital statistics or deaths facts that also come down from CDC. And then most of you are no strangers, particularly this influenza season, to long-term care outbreaks associated with respiratory illness. So as I mentioned, emergency department ILI data is entered by the staff here at the department into Epicenter. And schools and long-term care facilities report directly into that module. About 2 years ago, we actually sent letters out and continue to send letters out to those individuals who are reporting into our CDRSS ILI module. We want them to actually have their own usernames and passwords to be able to enter that data directly so that local health departments aren't burdened by that data entry into that ILI module. Some local health departments still choose to collect that information and enter it, and we're fully supportive of that as well. In addition, any local health department can actually have access to the ILI module to view the information that's input from their systems. And so if you have any questions on that, you can always reach out to me. As I mentioned, influenza is a laboratory reportable condition. Positive influenza lab reports are required to be reported through CDRSS, and again, those ELR labs, they're required to report all positives. That would be rapid, culture, or PCR. If they do not have ELR capabilities, we request that they hand enter culture and PCR results into CDRSS, and that any rapid data they enter through the aggregate rapid data in the ILI module. As far as reporting and investigations by local health department for influenza, all the influenza that comes in through ELR is automatically entered as confirmed and e-closed. Sometimes we have laboratories who will be entering items manually. So again, we do have some hospital facilities who are entering culture or PCR data, and they may put them in as RUI pending. Again, I want to reiterate that no investigations are needed, and cases can be closed out without an investigation. There are some exceptions to this, which I'll cover on the next slide. Occasionally, we get an ELR reported as an influenza A, H5, or an H7. These will also go in as RUI pending, and they do require investigations, and I'll cover that in the next slide. So what requires investigations from local health departments? Well, first of all, if it's a pediatric influenza case, any pediatrics less than 18 years of age who've been admitted to the ICU or have died is reported. We do have a memo that's on our website. You can see the link to that memo that got published at the beginning of this flu season. And then what happens is we actually add a survey to those cases, and we ask folks to respond to the additional questions. It should be noted that often when we get these results via ELR, we know the age of the child, but we don't know if they were just seen in the emergency department or in the ICU. So we do ask if there's a way that you can just indicate that this child was only seen in the emergency room or was not admitted to the ICU in those cases. It helps us really close out those cases much more quickly and get them off your plate. But again, that's only for those kids less than 18. The other type of influenza that does require investigations are laboratory reports that are indicative of a novel influenza strain. So again, anything that's an H5 or an H7 or unsubtypable. And I'll talk a little bit about that in the upcoming slides. So those are cases that would require an investigation. And so cases that do not fall into one of these criteria do not need to be investigated by local health departments and can simply be closed out. So I'm hoping that all of you are used to seeing this and all are aware of the NJDOH influenza report. This goes out every single Wednesday. Most of the time, unless there's some other extenuating circumstances. In addition, as soon as that links message goes out, it's also sent to our web folks for them to post it to our website. A lot of people don't know that these are all posted to our website and all archived. And so I've included the link highlighted in yellow here for folks who are interested in viewing it on the web versus through a linked message. So I just want to bring to your attention that last year we did add some additions to our reports. And the reason that we did that was because the information that we were providing in reports prior were simply the rapid influenza test data that was going into the ILI module. Clearly, because influenza is a laboratory reportable condition, we're getting many more test results through actual CDRSS ELR transmission. And we wanted to make sure that we were providing that data in addition to just the rapid data. And so there are two additional graphics that are added to the flu report, which include all CDRSS data that's actually recorded for influenza. So in the next couple of slides, I'd like to just address some of the common questions that come to me and what we do to actually assess those questions and why some of the questions are a little bit more difficult to answer. So, the two common questions that I always get is, when is the peak of influenza activity and when is it over? And how severe is the flu season this year? And so many of you who have heard me speak before know that I often will say the only thing that's predictable about influenza is that it's unpredictable, and that if I knew the answer to many of these questions, I would play the lotto more. So when we talk about peak activity, we've often looked to see our viral data. And so this is a graphic that I'm hoping many of you have seen before. This is influenza positive by PCR. Again, this is only PCR testing results. And here you can see that in about the week ending January 7th, appears to have been the peak of activity, and we continue to go down from there. Now, at any given influenza season, we typically see about 5 to 6 weeks of high influenza activity, with one of those weeks predominating. And then on either side, what we call the shoulder weeks, is kind of where we see decreased activity. And usually this will continue well out into sometimes March, sometimes April, sometimes well into May, depending on how long the influenza virus lingers. Currently in this influenza season, we're seeing a predominant virus of influenza H3, and for a number of reasons this is concerning, and why we see a little bit more severe cases in addition to an increased number of long-term care facility outbreaks. So this is just to highlight that this is a full season of data. On the top left is the 15-16, and on the bottom right is the 14-15 season. You can see what I was talking about, that usually there's a single week that predominates as a peak, and then it kind of trickles off from there, sometimes into April and or May. The 15-16 season was very late. You can see the peak didn't occur until well into March, and we had seen cases well into the end of May. Versus the 14-15 season, which was a little bit more typical. Mid-January was the actual peak of activity, but we also saw influenza B activity circulating well into May of 14-15 season. This is just a graphic. This actual data comes from Epicenter. And again, this displays the % ILI visits and admissions associated with influenza. And certainly you can see that the PCR data that we just looked at mirrors exactly what this is. So we begin to see that peak of activity right around the first and second week of January. Similarly, these are our ILI net providers. Again, those providers who send us the total number of visits, and the visits broken down by age group that are associated with ILI. And again, you can continue to see right around the first and second week of January the uptick in the number of cases. And this is long-term care facility data. And again, this is only data from a select number of facilities who are reporting their total census and the number of individuals on a single day in a given week that have ILI. This really doesn't mimic the long-term care facility outbreaks that we've been seeing because it is actually from a very small number of long-term care facilities. But again, you can still see that the first and second week of January, we did see that peak. So some other questions that we often get is, do I have an outbreak and do I need to report it? And do I really need to prophylax the entire facility? So let me remind you yet again that we do have outbreak guidance for both long-term care facilities and schools and daycares that are posted on the NJDOH website. If you go to the Communicable Disease Service webpage on A to Z, it's under outbreaks. As many of you are already aware, all outbreaks, regardless of the disease that's associated with them, are immediately reportable. I would ask that you review the guidance for criteria of outbreak and response in these documents. I'd like to just remind everybody that one confirmed case of influenza via any type of testing method, whether it be rapid or PCR, plus other individuals within that facility with symptoms consistent with influenza-like illness, is a confirmed outbreak. And any confirmed outbreaks require antiviral prophylaxis of the entire facility. And when I say the entire facility, it's not meant to be a wing or a unit. It is, in fact, the entire facility. Our regional epidemiologists have done a great job of reminding everybody of this particular recommendation, and many facilities that have been very compliant in working with us. As far as school outbreaks, just a reminder that we expect there to be some respiratory illness in schools, but we also don't expect there to be a lot of kids coming to school sick. And so it is really important to stress the exclusion criteria for schools. Again, that's 24 hours fever-free without fever-reducing medications. Children can return. And I'd also point everybody to the school and daycare guidance, where we do give some examples of how we define outbreaks in schools and daycares. And certainly if there are any questions and you do get these reports and want to know whether you should call it an outbreak, certainly give us a call, talk to your regional epidemiologist, and we'd be happy to discuss with you whether we just want to remind the school to monitor for illness or put in certain infection control practices, or whether we want to treat it as an actual outbreak and do additional either case findings or additional infection control practices. So So to date in the 16-17 season, this is actually about 2 weeks old, we've had 33 respiratory outbreaks in long-term care facilities. This number has probably gone to close to 50 outbreaks of respiratory illness in long-term care facilities. And again, you'll see that because H3 predominates, we see a large number. In comparison to the 15-16 season, the entire season we only had 38 respiratory outbreaks in long-term care facilities, and that was when 2009 H1N1 was the predominant virus. And again, 2014-15, when H3 was the predominant virus and we had a vaccine mismatch, the entire season we had 116 respiratory outbreaks in long-term care facilities. So one of the things that you probably have, if you've had a long-term care outbreak and you spoke to your regional epidemiologist, these are some of the questions that you've been asked to obtain from the facilities. We'd like to know the vaccination rate in both residents and staff. This actually helps us better understand why some of these outbreaks in these long-term care facilities are occurring. We've had this season a lot of long-term care facilities with very high vaccination rates still develop outbreaks within their facilities, and so that tells us that maybe there's something else that may be going on. Do they have sick workers that are showing up to work? Do they maybe need to encourage additional staff vaccinations to help prevent the illness from coming in? Do they have to do some additional reminders for visitors who might be sick and coming to visit their loved ones? We would really like to know the testing that is conducted, not just that it's a positive influenza, but what type of test. Was it a rapid test? Was it a PCR test? Was it a culture? And then what the result was, whether it was an influenza A or B. And if a subtype for influenza A is available, we'd also like to know that. This really helps us capture the total number of long-term care facility outbreaks that we're seeing and quantify those that are actually associated with influenza versus associated with some other non-influenza illness. Additionally, we would like to know about whether the individuals who are confirmed cases of influenza have received treatment. And again, that's with an antiviral, and that's 2 doses, a dose twice daily of antivirals, or if other residents have received prophylaxis. And again, if it's a confirmed outbreak, that would be prophylaxis of the entire facility, and then it's a single dose of antivirals once per day. And the duration of those are extensive, usually 2 weeks beyond the actual report. And your regional epidemiologist can help you calculate how long the duration of prophylaxis should go within a facility for a long-term care outbreak. So another common question that I often get is the vaccine a good match? And there's a few different things that we can look at here. So as far as whether the actual viruses that are contained within the vaccine actually match the viruses that are circulating, that data comes from CDC, usually through antigenic characterization data. And this is actually from the CDC Flu View report, and I have provided the website of that on the bottom right of the screen. And so here you can see that for the most part, influenza viruses that CDC has tested, again, that come from states all over the country, it indicates that the viruses that are currently circulating do in fact pretty much match the vaccine that we've administered to folks. You see that there is a slight drift in the H3N2. Not only about 5% seem to have some reduced sensitivities, titers to the actual strain that's in the vaccine. But by and large, there's a pretty good match. So the second question that I would just like to address is that there's also studies that are conducted by the CDC that produce vaccine effectiveness information. And this information is also really important because this is actually what happens in the real world. And so CDC enrolls a number of providers who look at whether an individual has been vaccinated or not, confirms the proof of that vaccination, and then when they see them for an influenza-like illness, they are counted as a report. And CDC actually does vaccine effectiveness, so essentially how effective is the vaccine in the real world, in real people. These study estimates are due out sometime in the next 2 weeks or so, and so it will really help us not just to say that the vaccine is actually a good match to the vaccine strains, but also to talk a little bit about whether the vaccine is effective when we actually use it in the real world scenario. So the other question that we often get is, should I still get a vaccine? The recommendation from CDC is that individuals should consider vaccination as long as influenza is still circulating. And I think for those of us who are in the flu world or in the local health departments know that flu is still circulating. So yes, influenza vaccine should continue to be recommended. The other question we often get is, should I get quadrivalent or trivalent influenza vaccine? And the answer is any vaccine is a good vaccine. And so there is no specific recommendation in favor of either. It's really a choice that you should make with the clinician who is providing that vaccine for you. The other question that we'll get as soon as influenza begins to slow down is information about healthcare provider restrictions. So many facilities do have infection control practices in place or vaccination mandates within their staff that actually say that during the flu season, quote unquote, any non-vaccinated workers must wear a mask. And then we often get phone calls that say, well, when can I tell my healthcare workers that they can stop wearing masks? Well, unfortunately, these are facilities' policies that they've put in place. These are not state mandates. And so when facilities put these policies in place, they also need to have protocols in place that allows them to both implement when they start and to remove those restrictions. And so I would remind facilities that you need to have those protocols in place so that you know when to implement and when to remove those restrictions on healthcare providers. So we'll quickly move into novel influenza. And I want to talk a little bit about H7N2. Many of you may have either seen links messages or heard a little bit about this. This is actually a respiratory illness in animal care centers that were associated with cats in New York City. The issue began in November, and it was identified as a low pathogenic H7N2 virus, which had never been seen before in cats. It had been in other animals, but never in cats. And 2 prior cases that have been identified in humans in 2002 in Virginia and in 2003 in New York City. There were numerous cats ill, one that had died who was up in age and had other health complications, 1 human illness and a person with prolonged exposure to some of the sick cats. There were a small number of animals that actually had made their way into New Jersey, predominantly through rescue groups. And we had actually followed up with all of those rescue groups and had determined that none of the animals nor their caretakers were actually ill. As I had mentioned, there was a links message that was sent out on December 17th with guidance predominantly for clinicians to help identify any cases, either in humans or animals, for anybody who may have either been to the shelter or had adopted an animal from the shelter. To date, there's actually a fairly large quarantine facility in New York City that is housing any animals that have come from the shelter. And there are workers who are volunteers from the ASPCA who are being trained in appropriate PPE to care for these animals until they actually can prove that they're no longer shedding the virus. We have been getting some of those lists from the ASPCA to check on the workers to make sure that they remain well. And so some local health departments may have gotten a phone call from us saying that we're going to reach out to these folks just to make sure that they are in fact well and they know who their public health officials are in their jurisdiction should something happen. H5N8 has been rapidly spreading, predominantly among migratory birds. We've had a lot of reports of migratory birds being found with H5N8 in Asia and Europe. Again, it's causing some deaths in wild birds and some outbreaks in domestic poultry, which is often concerning to us because sometimes it can signal to us that there is additional circulation in those animals. But to date, there's been no human illnesses that have been detected. So H7N9 is still circulating. There have been recent human cases as recent as January 2017. There was a recent links message sent out this week that included guidance. The guidance is actually also posted to the influenza surveillance section of the New Jersey Department of Health website. Essentially, this guidance recommends similar messages that we give for all novel influenza viruses, and that's for clinicians to ask about both travel history and animal contact. Those are 2 really important things for us to understand. And then also a reminder to laboratories that if they do get unusual testing results, they have a PCR with a very high CT value with unusual results or any unsubtypable results, that they should be forwarded to the state public health lab for us to run additional PCR testing. Again, the next two, H5N1, which is what kicked off a lot of our pandemic influenza concerns back in 2005, is still circulating, still predominantly in Southeast Asia. There are occasional limited outbreaks, but by and large, they've remained within Southeast Asia. H3N2V, again, is a swine virus still circulating. There have been 18 cases reported in 2016, and they've been predominantly from Michigan and Ohio. And again, H3N2V is associated with prolonged exposure to swine. And so this happens a lot with different types of agricultural markets and fairs where there's prolonged exposure to those swine or extensive contact with those swine. There have been a lot of guidance documents and a lot of efforts put into these agricultural fairs to try to limit the amount of infections associated with H3N2V. And so that's the influenza update, and I'll take any questions you might have. So there's a question here about how are you working with all urgent care centers, and are they considered ambulatory care? We do work with some urgent care centers. There are some new electronic resources where we've connected with some of the ready clinics that send data to us, and they actually get included into our ILI-net data as they're considered healthcare providers. So we treat them as if they are individual providers and are included in our ILI-net feed. And we work with those directly because we're actually working with national offices that are associated with that. The next one is, if we receive a paper lab report from a lab without typing, should we enter it into CDR-SS? Again, it really should be, it depends on where the lab is from. If you're getting a paper lab report and it's from within the state, those labs should be entered by those acute care facilities if they are a PCR or culture result. If they are not, I would ask that you let us know and we can alert our CDR-SS admin staff to do some additional training with that facility. If it's a lab that's from out of state and not somebody who would be connected through ELR, I would suggest that you do not need to enter those. I don't want to overburden local health department staff with entering additional laboratory results. Again, influenza is a laboratory reportable condition, which means it should be reported from the laboratories. And so we do get an overwhelming number of influenza labs, and we are able to make good surveillance decisions based on the information that we're getting. So I don't want to overburden local health departments with doing individual entry. Again, if there are some specific questions associated with that, feel free to shoot me or the Influenza Advisory Group an email, and we're happy to discuss that one-on-one. Where can we find out the vaccination rate of residents and staff for influenza? You need to ask the facility themselves. These facilities, long-term care facilities, should know when they did influenza vaccination among their residents, and they should actually have that recorded within their medical charts. So in general, when those things happen, that's something you should pose to the long-term care facility when they report the outbreak. So the last question that I have here is, what is the recommended antiviral for prophylaxis in a long-term care facility, and who pays for it? So the recommendation is either Tamiflu or Relenza. We actually have documentation that we are happy to provide on the actual dosage of that and duration. And as far as who pays for it, the facility. If you look at Medicare regulations, antiviral medications are paid for if an outbreak is ongoing within the facility. So prophylaxis and treatment courses are paid for by Medicare if there's a documented outbreak within that facility. So the cost is not borne by the facility. It actually can be charged through insurance and should be covered. Okay, one more question. Do local health departments need to conduct investigations regardless of age for any novel influenza strains? And the answer is yes, absolutely. If it's a novel influenza strain, it does not matter the age of the individual. All novel influenza cases need to be investigated immediately. So the another question is, so the only labs that need to be entered are PCR or culture. That's correct, individually entered into CDRSS. If you're a hospital laboratory or a laboratory, you need to enter in patient information and demographics if it's a PCR or culture results. And we'd like to work with you to make sure that your rapid results are being submitted to us in an aggregate format, essentially the total number of tests that are performed and the number that are positive. And that's all for me. Thank you so much, everybody. Have a great afternoon, and I'll turn it over to Namita.
Thank you, Lisa. Again, if you think of any questions, you could send that in toward the end of the presentation, and I will forward it to Lisa to have her respond to any specific influenza questions. Our next presenter is Kim Cervantes, formerly of the Regional Epi Program. She is currently the Vector-Borne Disease Coordinator and will be providing an update on Zika.
Thanks, Namita. Good morning, everyone. Well, Namita just made my announcement, but I was going to announce a staffing change within the Vector-Borne Disease Program. Kara McGinnis-Palat, who many of you may have known, she was our CDC temporary Epi field assignee, and she has recently accepted a position outside of New Jersey. So for the past 1.5 weeks, I have assumed the position of the Vector-Borne Disease Program Coordinator, and hopefully I know most of you from the Regional Epi Program, and I look forward to working with you in this new capacity. We will be hiring a Zika epidemiologist who Kara was also taking a lot of that work as well. So today I'm going to talk a little bit about some new Zika subgroups in CDRSS. And in June 2016, CSTE had approved the use of these 4 new subgroups to characterize Zika versus infection versus disease and congenital versus non-congenital presentation. So these subgroups should be live today in CDRSS. I know you'll be excited to see them. And moving forward, we are asking that you characterize the Zika cases in your jurisdiction based on these subgroups. CDS staff will be going back and reclassifying all of the 2016 cases according to the new system. So the 4 subgroups are Zika virus disease congenital, Zika virus disease non-congenital, Zika virus infection congenital, and Zika virus infection non-congenital. So congenital means present at birth. For the congenital presentation, we're looking at abnormalities or birth defects. So things like microcephaly, eye or hearing concerns, etc. So if we have a neonate presenting with an abnormality, we would be classifying that as Zika virus disease congenital. If there are no abnormalities, the case would be subgrouped as Zika virus infection congenital. In the non-congenital presentation, symptoms are based on an acute infection and include the typical fever, rash, joint pain, and conjunctivitis. If the person is symptomatic, it would be subgrouped as Zika virus disease, non-congenital, and an asymptomatic person would be classified or subgrouped as Zika virus infection, non-congenital. So for workflow, if you're entering a new case into CDRSS or if you're working on an existing case, you should review the information on the type of presentation, the age of the patient, and the presence or absence of symptoms. Based on that information, you should change the subgroup from pending to one of the 4 new subgroups. And once you select the subgroup, the Signs and Symptoms tab and the Risk Factor tab will be tailored for that subgroup. Okay, so we're going to do a poll question. All right, so a 2-year-old child recently traveled to Puerto Rico. He is asymptomatic and has lab evidence of Zika virus. Which subgroup would be used in this scenario? So we have Zika virus disease congenital, Zika virus disease non-congenital, Zika virus infection congenital, and Zika virus infection non-congenital. Okay, excellent. The correct answer is D. This child does not have any symptoms, so it would definitely be one of the infection subgroups. And this is a 2-year-old, so this is not present at, this is not a newborn, so it would be non-congenital. So the answer is D. But please keep in mind that this child would actually not fit the DOH criteria for testing through PHEL. However, you may see cases like this that have been tested at commercial labs. All right, we're going to move on to a second poll question. Okay, so an infant is born with microcephaly and a hearing defect. Her mother has evidence of Zika virus. Infant tests are pending. Which subgroup would we be using here? So we have Zika virus disease congenital, Zika virus disease non-congenital, Zika virus infection congenital, and Zika virus infection non-congenital. Okay, excellent. This is super easy. The correct answer is A, Zika virus disease congenital. This is obviously an infant at birth, so it fits the congenital grouping, and they do present with an abnormality or a defect, so that would count under disease as well. Keep in mind, CVS will be classifying most of the infant cases since we are working directly with the birthing facilities on those deliveries and the specimen collections. Okay, I'm going to go over some of the labs. They can be a bit confusing and hard to interpret. Tests that confirm Zika infection or disease include culture, which is rarely performed, PCR or serology, accompanied by confirmatory plaque-reducing neutralization testing or PRNT. A positive PCR test would confirm a Zika virus infection, but a negative PCR would not exclude it. That's because the peak viremia is thought to occur several days before illness onset until 1 week after onset. So that's a very short window. We often have negative PCR tests because the virus may have cleared at the time of specimen collection. And most persons that we're testing are asymptomatic, for which the role of PCR testing is even less clear. Zika virus IgM antibodies develop during the first week of illness. The duration of IgM antibodies is unknown, but they do wane over time and are thought to persist about 12 weeks after exposure. Zika virus test results can be difficult to interpret because of cross-reactivity with other related flaviviruses, especially if the patient has been previously infected or vaccinated with a flavivirus, such as West Nile virus, dengue, Japanese encephalitis, or yellow fever. In addition, the neutralizing antibody titer against a flavivirus to which the person previously was exposed might be higher than the titer against the virus with which they were most recently infected. So for example, a person who was previously infected with dengue virus might respond with high levels of neutralizing antibodies against dengue when later infected with Zika. The IgM positive antibodies with the PRNT titers, if they're positive against Zika and negative against dengue, are considered confirmatory. The presence of neutralizing antibodies against multiple flaviviruses makes it very difficult to determine which virus was responsible for the recent infection. So these are considered probable lab tests for Zika. And much of the New Jersey population who have been tested for Zika have also shown reactions to dengue or another flavivirus, which makes the ability to diagnose very difficult. For persons who are symptomatic and being worked up for Zika, and who we can test within 2 weeks after onset of symptoms, they will be tested at the state using PCR on serum and urine. If that PCR is negative, the test will go to an IgM, and if that IgM is equivocal or positive or inconclusive, then we will go to the confirmatory PRNT testing. Keep in mind, for persons tested at commercial labs, those tests will be run based on what the physician orders and may not follow this algorithm. So how would you interpret the lab results? For persons who are symptomatic, if the specimen is collected within 7 days of onset, a negative PCR and a negative IgM will rule out Zika. If we only have a negative IgM, this may reflect specimen collection before the development of the detectable antibodies, because again, these form in the first week. If the specimens are collected after 7 days after onset, a negative IgM for both Zika and dengue will rule out infection with either virus. Now this slide is busy, but stay with me. So if the Zika or dengue IgM is positive, equivocal, or inconclusive, it will be sent for PRNT testing. And the PRNT is really needed to determine if the IgM indicates a recent infection or if it's a false positive. We have seen very high numbers of false positive IgM results, particularly at commercial labs. So it's really important to wait for those PRNTs. So if the PRNT is positive against Zika and negative against another flavivirus, that would be confirmatory for Zika. If the PRNT is positive for Zika and another flavivirus, all we can say is that there's evidence of a recent infection with an unknown flavivirus. If the PRNT is negative against Zika and is collected after 7 days after onset, we can rule out Zika. And if the PRNT is negative and the PCR is negative, collected less than 7 days, we can also rule out Zika. All right, so let's see if this question is as easy as the others. So poll question number 3. Okay, so a negative PRNT collected less than 7 days after illness onset in the absence of a PCR test does not rule out Zika. Why? A, there could be cross-reactivity with other flaviviruses. B, the specimen may have been collected before the IgM antibodies have developed. C, only PCR can confirm Zika in symptomatic persons. D, PRNT isn't valid unless there's a PCR test also. Or E, I don't know. Okay, excellent. The correct answer is B, because the specimen may have been collected too early to detect those IgM antibodies. So in this particular case, a PCR should have been run also. And if both were negative, then we could rule out Zika. But again, if someone is tested at a commercial lab, that physician may not order a PCR test and may only order serology. Okay, so the majority of people tested in New Jersey at PHEL are asymptomatic pregnant women. We request testing 2 to 12 weeks from the last exposure, which is usually travel or sexual exposure. And in these situations, the IgM test will be run first. If it's positive, it will go to PCR testing. The interpretation is the same as for symptomatic persons. We only recommend the testing through the 12 weeks because the IgM antibodies wane and are unlikely to be detected. So it's important when you're approving specimens that you only approve the tests within that 12-week period and that you let the provider know that it's important for the patient to have their blood drawn also within the 12 weeks. If it's outside of the 12 weeks, PHEL will not run the test. And we have several forms that have been generated by you in CDRSS for approval where the patients either are not going for their test or they're going outside that 12-week window. So anything we can do to encourage providers to pass that message on to their patients would be good. And of all the tests that PHEL has run that have been more than 12 weeks from the last exposure, none have been positive on IgM. So it really is a waste of our resources. So for classifications, some local health departments have already been classifying all of their Zika cases. The links message we had sent out several months ago had asked you to classify the commercial lab cases. But at this point, you're approving most of the cases tested through PHEL. You have access to the clinical, the epi, the lab information, and it really makes sense for local health departments to classify these cases as you would for any other disease. CDS will continue to classify the infant cases, and we ask that you still notify us of any infant case you become aware of. So looking a bit at the congenital presentation, these are the primary abnormalities we're interested in, as listed on the screen. And as part of an infant workup for any defect, providers should also consider testing for other congenital infections, such as syphilis, toxoplasmosis, rubella, cytomegalovirus, herpes simplex, etc. So in CDRSS, this is the Signs and Symptoms tab for an infant with an abnormality. You'll see at the top the asymptomatic sign and symptom will be there. That has to be in all subgroups. It's just a idiosyncrasy of CDRSS. But if we're looking at one of the disease subgroups, that asymptomatic should not be checked. Any details related to the abnormality should be noted in the attributes field. For example, the head circumference percentile is noted in the example on the screen. There's a lot of information on these slides. I'm not going to read them, but you'll have them for reference. These are the updated case classifications for each of the, well, actually for the disease subgroups. So for the case definition for the Zika virus disease congenital, the infant must meet the clinical criteria, as I showed on the previous slide, and have positive lab tests. We also need to know about the infant mother's Zika exposure and her lab evidence of Zika infection. A few notes on the case definition. This specifies infant specimens should be collected within 2 days of birth, but we may accept them later if the infant's not born in an area with active local transmission. Also, we would only order PRNT testing if the mom did not have PRNT results. And that's because PRNT tests for IgM, IgG, and IgA antibodies. The IgG antibodies cross the placenta, so if mom has positive PRNT results, we can assume the infant will as well. The risk factors we're looking for in a congenital presentation are the mother's travel exposure, whether she had a sexual exposure, and if she has lab evidence of Zika. Less common, did the mother have a blood transfusion or an organ transplant? For the infant, you'll also see there's a question on if there was a history of travel. This would be for the infant in the first 2 weeks. Again, this is a risk factor that's present on all subgroups. We generally would not expect to see this on a disease congenital presentation because, again, congenital is present at birth. So looking at the non-congenital presentation, the clinical criteria would be one or more of the following that's not explained with another etiology. So the first option is a clinically compatible illness. Again, we're looking at the fever, the rash, joint pain, or conjunctivitis. The second clinical criteria is a pregnancy complication, which could be either a fetal loss or a fetal or neonatal abnormality. And the third grouping is Guillain-Barré or another neurologic manifestation. So the second bullet could be a little confusing. If we had a pregnant woman who had a baby with an abnormality, the mother would be a Zika virus disease non-congenital case. Her baby would be a Zika virus disease congenital case, assuming the lab criteria are also met. And both of those cases, mom and baby, should be linked in CDRSS. So this is where they would be linked on the contact tracing tab. And again, most of this linkage is actually done by CDS because we're working with the deliveries and we would have the information on those infants at birth. So these are the signs and symptoms for a non-congenital disease case. So they include the typical symptoms of illness, but they also include the symptoms related to those pregnancy complications, including fetal loss, and Guillain-Barré or those neurologic symptoms. And again, the asymptomatic should not be checked in one of the disease subgroups. This is another case classification for the Zika virus disease non-congenital. It again requires meeting the clinical criteria that was presented on the previous slide, having positive lab tests, and an epi-linkage, which is usually travel or sexual exposure. The risk factors we're looking for in a non-congenital presentation include the travel history, with the location noted in the attribute field and the dates of travel, if the patient relocated to the United States from an endemic area and when, if there was a sexual exposure and the dates for that, and if so, what the sexual partner's travel exposure was. So we want to know what country that sexual partner had traveled to and his or her dates of travel. Also want to know if the patient mentions mosquito bites or if they spent considerable time outdoors. Less commonly, could this be a laboratory exposure, and would they have received blood transfusion or an organ transplant? One of the most important boxes, and I put a little arrow there, is if the patient was exposed during pregnancy or in the 8 weeks prior to conception. Now, I know that pregnancy information is also noted under the clinical status tab with the estimated date of delivery, which is wonderful. But we need to have this risk factor checked here in order for us to run reports to know who is pregnant and who we need to follow up on through that delivery. So it's really important to make sure that this box is checked if you're investigating a pregnant woman. The last risk factor on this page is suspected local transmission. This would pretty much be if there's no other risk factors identified. And again, if you suspect local transmission, please call us to discuss because we'd like to work on that with you. And these are looking at the two infection subgroups, so Zika virus infection congenital and Zika virus infection non-congenital. And basically, these subgroups have the same epilink information, the same lab evidence as their disease counterparts, but they do not meet the clinical criteria. So for both of these, under the signs and symptoms, this is where you would check the asymptomatic box in CDRSS. So some tips on investigating and keeping cases open in your jurisdiction. If an IgM test has been ordered either through us or commercially, you will likely get that IgM test result much in advance of that PRNT result. So we do ask that you leave those cases open as reports under investigation until the PRNT is available. That IgM should only be seen as a preliminary positive. It can take a significant period of time between the IgM result and the PRNT result, particularly when they go commercially. So commercial IgM positive tests, like at LabCorp request, they're all sent to CDC for PRNT testing. They have a significant backlog. We have reports where it's taken months to get that PRNT. The time frame for testing through PHEL is much less. We actually send our IgM positives to Wadsworth for PRNT testing, and that turnaround time is much quicker. But we do ask that you leave those cases open until the PRNT result is in. And we have been using a possible classification. We will no longer be using that. We were using that to capture asymptomatic persons. But now that we have the 4 new subgroups, we will no longer be using the possible. Okay, so Zika and dengue, as I've been mentioning, there's a lot of cross-reactivity between the IgM tests for the various flaviviruses. And CDC is still consulting the states on how to handle cases with positive test results for both Zika and dengue. There are updated case definitions as well for dengue, which we have not yet implemented, including some new subgroups. There's going to be a subgroup for dengue, one for dengue-like illness, which would be the fever only, and one for severe dengue disease. We're currently working on an updated chapter for dengue, and we'll be introducing those 3 new subgroups into CDRSS as well. So for now, we're asking that you investigate persons with positive lab tests for Zika and dengue as 2 independent or separate cases. Please try to include as much clinical information in the case as possible, and just note the CDRSS case ID number for the other case in the comments field. So if you are in the Zika case, note the CDRSS number for the dengue case and vice versa. So persons who are under investigation for Zika may also have tests ordered for dengue. If the specimens go for PRNT testing, it will include both Zika and dengue PRNT. So almost every person who has been tested through PHEL who has positive PRNT titers for Zika has also had positive PRNT titers for dengue. And this means that the New Jersey population being tested for Zika also has high levels of likely previous exposure to dengue virus. The positive IgM and PRNTs for dengue will open a case of dengue in CDRSS, so you may be seeing an increase in cases of dengue. And we're asking that you note the investigation information in both cases if they meet each of those diseases case classifications or definitions. So CDS will be reviewing all of the cases that have test results for both Zika and dengue. We're going to be reviewing the clinical, the epi, and the lab information, and we'll go ahead and reclassify if needed. CDC estimates that true co-infection with Zika and dengue is very rare. So if we have a PCR positive test for either disease, that would be confirmatory for that disease. If we don't have PCR testing and we have positive PRNTs for both Zika and dengue, CDC recommends a clinical review of the case. So we will do that here and make the determination on which virus we think is the likely cause of disease. So again, the more clinical information we have on signs and symptoms in the case, the easier it will be to do that clinical review. So as I mentioned, we are working to post an updated disease chapter for dengue. When that's complete, we'll also be sending out a links message. And some other activities, we're working closely with the Family Health Services Division here at the Department of Health to provide additional education to clinicians and birthing hospitals for infant testing and surveillance. Family Health Services is the group here that is responsible for the pregnancy registry and collecting information from moms and following those babies through 1 year of life. We do ask that you still call CVS with any upcoming or recent deliveries that you are aware of. We do try to work with them prospectively so we can prep the hospital on what specimens will need to be collected. And we don't yet have a Zika disease chapter, but we are working on it, and we know that a lot of information on our website is out of date, so that is certainly a high priority, and we are going to try to update that website so that you can find the guidance more easily. This is an upcoming conference that may be of interest to you or may be of interest to maybe some other colleagues in your agency. It's hosted by the Family Health Services Division in conjunction with the New Jersey chapter of the American Academy of Pediatrics. It's going to be covering newborn screening and surveillance, and there are going to be a couple talks on Zika surveillance and also the pregnancy registry. There is a fee for in-person attendance, but this is really nice. They are going to live stream it for free. So I do encourage you to share that with any interested colleagues, and registration for that is on the NJDOH website. And with that, I can take a few questions. And I have some other members of my Zika team here to help me since I'm only a week and a half in. Let's see. The question is NJDOH working on travel advisories for childbearing women and men with the international airports to educate them about Zika and consider not going to Zika endemic countries? I'll ask Karen and Kristen if they're aware of any activities with the airport. I know that Family Health Services is developing educational and counseling resources to identify pregnant women through different clinics and FQHCs and also through STD clinics to provide education for people planning a trip or who travel regularly, to inform them about those travel advisories, to distribute the Zika prevention kits and other educational messages. I'm not sure about the airport specifically. Karen? We're not aware of anything with airports. Let's see. Okay, a comment that the addition of a field about sexual partners' travel or exposure would be helpful to have on the Zika patient information worksheet submitted to the local health department by a provider. That's a good suggestion. We can certainly take that back. Another comment, health departments used to get a weekly email from the vector-borne disease program with updates in the number of vector-borne positive cases of humans, mosquitoes, horses, etc. Will this be resumed? Yes, it will. Those summaries are generally only sent out sort of during the vector season, during the mosquito season. So we would be resuming those in the late spring. So definitely look forward to those. And we were directed to still approve testing past the 12 weeks because it was sexual and stays in the sperm for 6 months. Where was that question? Is this not correct? The 12-week period is from the last exposure. So if it's pretty simple for travel exposure, right? If someone comes back on January 1st, you can go out 12 weeks. The sexual exposure is a little more difficult to characterize, but in terms of the testing for a pregnant woman, we will test 12 weeks from exposure. So if there has been a sexual exposure within 12 weeks, even though that's farther out from the travel date, because as you say, the virus can still be shedding in semen, we estimate for 6 months, then yes, that would be an appropriate exposure. So let's say a couple travel to a Zika-affected area in January. They become pregnant, or they're having unprotected sexual contact. We would look at a 6-month period as possible exposure for that male who had traveled, and as long as the pregnant person had unprotected sex within 12 weeks after that period, we would go ahead and test. I know that's really confusing. If you have any questions, you can certainly call, your regional epidemiologist or one of us to discuss it. But as long as it's within that 12-week, and that 12-week of sexual exposure has to be documented on the SRD1 form. So if you're looking at a sexual exposure that's going to look like it's more than 12 weeks after the travel exposure, because again, we're looking at that period where the male could still be shedding virus, that has to be noted in the SRD1 for PHEL to approve the test. Let me see. Do local health departments have to close out all Zika cases pending, even those without lab results? I think this is probably referring to cases maybe that you're creating with an SRD lab approval, maybe who don't go for testing. We are leaving those open for a while in terms of, I don't know if we have a time period for when we would want them closed out, but for now you could just leave them open, and we sort of run reports, and if we see a really long period of time between the case was created and the lack of a lab test result, we may ask you just to give the doctor a call to find out if they went for testing to make sure the specimen wasn't lost. But we are seeing persons who get the forms or maybe don't get the forms, but who are not going to get tested. And we're actually starting to take a look at that. There seem to be sort of differing numbers of persons who choose not to go for testing after getting the approval in certain counties. So we may be following up on that, but for now I would say leave them open. Okay, so with that, thank you very much.
Thank you, Kim. Again, if you have any additional questions, you could always send it to either my attention or to one of the presenters, and we will address it as we move forward. That concludes our webinar for today. Just wanted to mention a couple of trainings that we have coming up. All right, so here we go. These are some of the trainings that are coming up and meetings that we have scheduled in the next few months. Our Spring 27 Communicable Disease Forums will be in person, and they are tentatively scheduled for either the end of March or the first few weeks in April. And these are our in-person forums, and if you have any suggestions about topics that you would like to hear, or if any of you at the local health department or county level would like to participate in presenting an investigation or an interesting presentation from the local perspective, please reach out to me, hopefully by mid-February, and we can certainly accommodate that. We also have a healthcare-associated infections conference that's coming up. It's on May 10th at the Mercer Conference Center in West Windsor. There is a cost to attend. It is $1.20 per person. We also have the annual Drug Diversion Conference. This is the third one that we're hosting. That is scheduled for June 1st at the Rutgers University Bush campus. Again, there is a cost associated with it. It's about $50 per person, but it includes breakfast and lunch and continuing medical and just pharmacy credits as well. Again, as a reminder, if you're watching as a group, please send me a sign-in sheet so that everyone will be marked off as attended on NJLMN, which means that it will appear on your transcript and will provide the documentation for continuing education credits. Everyone registered on NJLMN will receive an email with a link to an online evaluation. We hope to have it out first thing tomorrow morning. Nurses must complete the evaluation and include your name and email address. Our nursing certificates will be sent out to those email addresses that we receive. And again, if we don't have any additional questions that we would like to address here, we will conclude the webinar, and our recording will be available on our Department of Health website within the week. Thank you all.